Hello and welcome to today's web chat about pelvic floor disorders. Thank you for joining us. My name is Ed Bottomley from the Michigan Medicine Department of Communication, and I will be your host for today's chat. 1 out of 4 women over the age of 20 suffer with some form of pelvic floor disorder, whether it be pelvic organ prolapse, urinary incontinence, or bowel leakage. But it's not something that gets talked about enough. That's why we're here today. You don't have to live with incontinence or prolapse. Our goal today is to give you the information and confidence you need to take action and regain the freedom you deserve. Of course, while making the decision to get treatment is the first step, today we will also provide you with some tips on how to choose a provider and a program that's right for you. We'll introduce our panelists in a moment, but first, just one housekeeping item. If you can't stay for the whole chat, or want to share the recording with a friend, a video of the chat in its entirety will be available on our Von Voigtlander Women's Hospital Facebook page, our Michigan Medicine Facebook page, our Michigan Medicine Twitter account, and posted to the Michigan Medicine YouTube channel soon after. So without further ado, let's meet our panelists and they'll give us a short introduction. First up, we have Dr. Pamela Fairchild.
Hi, I'm Pam Fairchild. I'm a urogynecologist here at the University of Michigan. I see patients at the Von Voigtlander Women's Hospital, as well as in Chelsea, Michigan, and Midland, Michigan.
Fantastic. Great to have you with us. Next up, we have Dr. Carolyn Swenson.
Hi, I'm Dr. Swenson. I am also one of the urogynecologists at Michigan Medicine. I too see patients at Von Voigtlander. I also see patients at the West Ann Arbor Clinic and up in Midland, Michigan. And I'm very excited to be here. Thanks for joining us.
Thank you, Dr. Swenson. And next up, we have Carol Buis, DPT. Carol, it looks like you might be muted. Perfect.
Yes. Hi, my name's Carol Buis. I'm a board-certified women's health physical therapist with a clinical doctorate in physical therapy. So I see patients at a offsite clinic at the Burlington building and am part of a whole team of Michigan Medicine physical therapists that see patients for pelvic floor dysfunctions at a variety of clinical locations outside of the hospital. Currently, I have the opportunity to also offer physical therapy at the OBGYN clinic at Von Voigtlander Hospital. Bringing a women's health PT directly into the OBGYN clinic is an exciting new initiative with the goal of making collaborative care more available to women.
Well, thank you all three again for joining us. And let's jump in, Dr. Swenson, with a general overview of what pelvic floor disorders are.
Sure, thank you, Ed. So pelvic floor disorders are really a group of disorders that mostly involve prolapse, urinary incontinence, and anal incontinence. Prolapse, also known as pelvic organ prolapse, is a condition where the pelvic organs drop down into and sometimes through the vaginal opening. In this condition, that can involve organs such as the bladder, the uterus, and the rectum. And symptoms that patients typically experience with prolapse are a sense of pelvic pressure or vaginal bulge. Prolapse is not generally painful, but sometimes there can be some pain and definitely discomfort associated with this. And this is a condition that can be, there's a range of treatments that range from conservative things all the way to surgery. Urinary incontinence is the involuntary leakage of urine. So this is having urine come out when you do not want it to. Common situations where this happens is with exercise, laughing, coughing, sneezing. And then with urgency incontinence, that can happen when you are trying to get to the bathroom and you just can't make it. And again, we have a range of treatment options for urinary incontinence as well. Anal incontinence really is the incontinence, the inability to hold in gas and stool. And this can be a very distressing condition for women, but is actually quite common and not something that physicians often ask patients about directly. So If this is something that you are experiencing, I would encourage you to seek out a urogynecologist or just an OBGYN in your area who can direct you to a urogynecologist to help manage these symptoms. And again, we have a wide spectrum of treatment options for anal incontinence as well. So those are kind of the main three domains and pelvic floor disorders that we're going to discuss today.
Thank you. Thank you for that overview, Dr. Swenson. Let's move straight on and delve a little deeper with some questions that we have here. The first one reads, are pelvic floor disorders common? And I'll ask Carol to answer that.
So that's a great question. And I truly appreciate the use of the word common instead of normal. Many women ask if what they are experiencing is normal. And that suggests that somehow, if it's normal, we should just accept it. And it's okay to be hurting or leaking. Women are often told, hey, it's just because you're pregnant, or it's just because you had a baby. Or sometimes we see commercials that try to make using incontinency products or pads as sexy. But just because something is a common experience does not mean that it's good or that there's nothing you can do about it. So women often succeed in improving those kind of complaints with a combination of medical and physical therapy interventions and sometimes surgery.
I'll move this over to Dr. Fairchild. Can I ask, what are the main risk factors for these disorders?
When we look at risk factors for pelvic floor disorders, some of the big ones are really anything that causes potentially trauma to the muscles and the soft tissues of the pelvic floor, or anything that causes strain on the pelvic floor. And for women, the big ones are really childbirth, and typically that's vaginal childbirth, but really merely being pregnant and the pressure that causes on the pelvic floor can have impact as well. The other things we look at are things that affect tissue, like smoking, or people that have connective tissue disorders or chronic medical disease, or obesity that can affect the pelvic floor function. And then anything that causes chronic strain, like a chronic cough or chronic constipation that you're straining a lot every day for. There are some familial patterns too, where some women tend to be a little bit more predisposed to have the issues.
Thank you for that. Dr. Swenson, it looked like you wanted to say something there.
Yeah, Dr. Fairchild is exactly right. Vaginal delivery is one of the big risk factors. And then the other one that is also worth mentioning is aging. So we know that pretty much every pelvic floor disorder increases, the risk of that disorder increases as we age. And while we don't exactly understand that right now, a lot of it does have to do with the loss of skeletal muscle that occurs with the normal aging process. The pelvic floor muscles are skeletal muscles, which I'm sure Carol will tell us more about. But just like we lose skeletal muscle mass kind of everywhere as we age, we also lose that muscle mass and muscle strength in the pelvic floor, and that can predispose women to a variety of pelvic floor disorders as well.
Thank you for that. Go ahead.
One last thing that I just wanted to bring up is that sometimes when women have gone through treatment for breast cancer or gynecological kind of cancers, they can afterwards also have pelvic floor pain and disorders. And you might not think about that because, oh, I had breast cancer. Why is my pelvic floor painful? But if that's happening, then you should seek some counsel of your physician, and there are things that can be done with physical therapy again.
Yeah, and you know what, expanding on that question, over to you, Dr. Fairchild, with this one. When is it time to see a doctor or have treatment for this problem?
Most pelvic floor disorders fall into the category of quality of life conditions. And what that means really is that you should seek treatment when they're affecting your quality of life. Well, I wouldn't say it's normal to leak a little bit of urine when you cough or sneeze. If you occasionally leak a little bit of urine when you cough and sneeze, and that has no impact on your life, it doesn't bother you, you're managing it, and you feel fine about it, you don't need to see a doctor about that. However, if you are leaking urine when you cough and sneeze, even if it's infrequent, then that's something that bothers you, you should definitely seek care. So it's really all about how much impact are these symptoms having on your quality of life? And then know that there are options out there to get treatment if you want better quality of life.
Thank you for that. And then moving naturally on, the next question for you, Dr. Swenson, what can I expect at a doctor's appointment?
Well, if you come to see one of us in the urogynecology clinic, generally what we do have a questionnaire that we have you fill out. And it is a couple of pages long, but part of that questionnaire are some validated questionnaires that ask you questions about your pelvic floor symptoms. And they might be, we ask about all of the symptoms related to disorders of prolapse, incontinence, urinary incontinence, and bowel disorders. So, and some of them are things you might not have really thought about, but maybe related to the problem that you're experiencing. So you'll fill out a questionnaire, and then we meet you and talk with you and get some more information about your history. And then we generally do a physical exam, which includes a pelvic exam, which probably is a little different than pelvic exams you've had in the past, because we're really assessing your pelvic support, your bladder support and function, and looking closely at your pelvic floor muscles and doing an assessment of those muscles as well. And then, often, depending on what you're presenting for, we can often offer you treatment options right then and there that can help with your symptoms right away. And then if you're interested in other treatments or surgery, then we'll give you more information about those other treatment options at that time.
Thank you for that. The next question that we have up reads, are ultrasounds and or other radiology diagnostics used to verify a patient has prolapse? And I'll push that to Dr. Fairchild first.
Typically, prolapse is a diagnosis that we make on clinical exam. Based on that exam that Dr. Swenson was describing, where we get pretty detailed in looking at the support of all aspects of the vagina and the uterus. We do use imaging in some types of evaluation, but the diagnosis of prolapse is not typically a radiologic diagnosis. There are some exceptions to that, but typically just the physical exam is what we need.
Okay, and then the next question reads, my mum says she has an overactive bladder. Is that actually a form of incontinence, and is it hereditary? And let's go to Dr. Fairchild with that one too.
So overactive bladder is really a symptom complex, and so it can include incontinence, but you can also have an overactive bladder without incontinence. What it really means is that you want to go to the bathroom more frequently than you think you ought to, and you have to be there pretty urgently. You have a very strong urge to get there that's uncomfortable. And some women will get that strong urge, be rushing to the bathroom and start to have some leakage. And some women just get that urge, they think, oh, I might leak, but they don't actually leak. And overactive bladder is really that complex of symptoms. It also includes sometimes getting up at night with a lot of urgency to make it to the bathroom as well. And there's not a strong genetic association for those symptoms, though we do see some trends in families. It's not like there's a gene we've pinpointed that's the overactive bladder gene at this point. And I think the key point is that symptoms are treatable and manageable.
In terms of that, can I move over to you, Carol, and ask you to talk about some of the things that can be addressed in physical therapy for overactive bladders?
So overactive bladder can come from a number of causes, as Dr. Fairchild just pointed out. And in PT, we'll look at a number of those. The first one is your bladder lining irritated? Because sometimes when you are dehydrated and your urine gets more acidic, you're going to get these urgent signals to get to the bathroom quick. And you get there and you don't have very much volume of urine to actually get rid of. So you find yourself going to the bathroom frequently, but not very much flow. That's because before your bladder is mechanically full enough to need to empty, you're getting the signal out, get this out of here. So sometimes the answer is actually when you're going to the bathroom too frequently and not very much flow is to drink more, not less, which is not typically what women think of. They think, I'm in the bathroom all the time. They restrict their fluids more, and then they end up making that get worse. So we talk about that, and there's other bladder irritants like alcohol and caffeine. Coffee is a two-edged sword. One, because it's got caffeine in it, and two, because it's also acidic. But even if you're pregnant, like some women, they need that 1 cup of coffee in the morning. It keeps their bowel movements regular. You know, we're not looking for perfection. We just need to, like, if you're drinking a pot of coffee a day, should probably bring that back. And then the other things are spicy foods, a lot of tomato kind of based foods, citric juices, and here's a surprising one, sugar and sugar substitutes. So if, say, for instance, your urine is not very pale to clear, but is darker, and then you go out and have a big piece of pie and some coffee, and you do that on a regular basis, you're going to start to irritate your bladder lining and make you want to go more frequently. So we talk about bladder irritants, and we actually look at the pattern of how frequently you're going and how many seconds of flow. So the next thing that can really affect it are tight muscles and restrictive connective tissue. That can really tug on you and give you that message again before your bladder is full that, boy, I've got to get to the bathroom. For that, you need a little bit of gentle help in physical therapy to decrease that tightness. And that's part of the internal vaginal work that we do. But it should be very gentle, and it shouldn't be something that is just like a horrible experience. It should be relieving. Most women are quite surprised. You know, they come in very anxious, worried about what's going to happen. By the end, they're fascinated at how well their body responds to just gentle techniques that help them feel a lot better. And then the other thing that if none of these things are helping and the symptoms are still there, we can use a small electrical stim unit called a TENS unit, or a transcutaneous electrical stim or nerve stimulator. It doesn't have a lot of power to it, but it can help give different signals to your nervous system so that you stop feeling that urgency all the time.
Thank you for that. That was a nice overview. I want to make sure we move along with our questions. I know that you touched on quite a few of these, but if there's anything further that we need to add, Carol, that would be great. The next question reads, I'm not sure my symptoms are really bad enough for surgery. It's really just when I cough or go running. Can special exercises help at this stage?
Yes, they can. This is stress urinary incontinency, and sometimes it's a matter of just doing Kegels. Sometimes if you have a lot of pain and restriction of your muscle and connective tissue, doing more Kegels is not going to help, because if you have a muscle that's already short and you ask it to shorten up more, it just can't help you very much. The other thing is if you have ever done a new exercise or sport and felt that burning and tightness in your muscles afterwards, that's due to lactic acid, which is a chemical reaction when your muscles do that work. It's a byproduct of the chemical reaction. Well, if your muscles are tight, then the little capillaries that run through it for your blood circulation can't flush that lactic acid out. So you get this cycle of pain tightening because you're reacting to the pain, and it just keeps going. So if Kegels are not helping your complaints or they're increasing your pain, you should stop doing them and seek the consultation of your doctor. Ask to see a pelvic floor therapist. You need a little bit of help.
Thank you for that. Dr. Swenson, does treatment for urinary incontinence or prolapse mean I need to have surgery? Are there non-surgical options?
Thanks, Ed, for that question. The answer is yes. We have lots of non-surgical options for urinary incontinence, and we also have non-surgical options for prolapse. So one of the question that Carol had was regarding pelvic floor muscle exercises for somebody with a little bit of stress incontinence. And in conjunction with pelvic floor physical therapy, we often offer patients something called a pessary, which is a silicone ring that goes into the vagina and helps provide the urethra, which is the tube you pee out of, a little bit of extra support, which typically is what patients with stress incontinence need. So, certainly with patients who just have leakage, with running or something like that, getting those muscles stronger, but then also having something they can use right away that works immediately when you put it in, is something they really appreciate. And, a lot of them had no idea. A lot of patients don't know that exists. So pessary is an option for incontinence. It can also help with urgency incontinence, that overactive bladder type of incontinence. And then a pessary also is a treatment, a non-surgical treatment for prolapse. So just like it supports the urethra for incontinence, it can hold the pelvic organs up back inside the vagina that are prolapsing down. We have lots of patients who choose to use a pessary instead of surgery, and they can use this long term and are very satisfied with this treatment option. So again, in answer to your question, yes, we have lots of non-surgical options. I do want to mention a couple other options for our urgency incontinence patients. Carol mentioned the use of a TENS unit for our overactive bladder patients. And we also have something that's similar to that for treatment of overactive bladder or urgency incontinence. It's called percutaneous tibial nerve stimulation, or PTNS is the acronym. And that's actually where we put a little acupuncture needle in the nerve that runs behind your ankle bone. It's connected to the nerves in your sacrum, and that's where the nerves to your bladder also come from. So this is just a way for us to access the nerves to your bladder in clinic. We put a little acupuncture needle in that nerve, apply a mild electrical stimulus through a TENS unit, basically. And it pretty much acts like a pacemaker for your bladder. So it kind of calms your bladder down and prevents it from contracting as much. And when that happens, you don't have the urge to go to the bathroom quite as frequently. There are also medications for your overactive bladder, and then we also do Botox for overactive bladder in certain patients who have failed prior conservative treatment options.
Thank you for that, Dr. Swenson. So let's shift over to Dr. Fairchild, if you don't mind, and we'll ask you to describe what surgical options there are for incontinence and prolapse.
Thanks for that, Ed. I'll address the prolapse surgical options first. The first thing I would say is that nowadays, almost all of the surgeries we offer would be considered minimally invasive. And we offer here at Michigan the whole range of minimally invasive surgeries. That includes a vaginal approach where you have no incisions on your abdomen, as well as laparoscopic or robotic approaches where you have small incisions on your skin. There's rare occasions where we still do open or big incision kind of surgeries, but mostly we're focusing on minimally invasive methods, which are great for recovery, and typically people are able to go home the same day and just do very well with those minimally invasive approaches. When we look at the surgeries we perform for prolapse, there's surgeries that we use all of your own tissue with absorbable sutures, which we would call native tissue repairs, and also surgeries where we're going to use some mesh in a very safe way to augment the repair and make it really better for some people that need mesh in their prolapse repair. Then when we're looking at incontinence surgeries, similarly, most of what we do now is pretty minimally invasive, small incisions on the vagina, and then small incisions just above the pubic bone for the typical slings that we do. We also offer, as Dr. Swenson was saying, surgeries for urgency incontinence, like cystoscopy with Botox, which is where we inject Botox, as well as a procedure called sacral neuromodulation, where we implant a bladder pacemaker that's a little bit more permanent than that PTNS procedure that Dr. Swenson already described. I think the key takeaways is that are that the surgeries are minimally invasive nowadays. People recover quickly and typically do very well. And we really offer the whole range here at Michigan and really tailor what you need based on your particular symptoms and what your preferences are.
Thank you so much for that, Dr. Fairchild. I really want to be aware of all of your valuable time, but I know we have quite a few more questions to answer. How does everybody feel about answering a few more?
Good.
Okay, maybe we'll go for 5 more minutes, see how many more we can answer.
Sounds good.
Okay, so the next question that I have up for Dr. Swenson, do I have to have a hysterectomy as part of my surgery?
This is a fantastic question, and the answer is no. So hysterectomy is something that in the past was commonly done for a lot of indications. Prolapse is a very common indication for a hysterectomy. However, a hysterectomy alone, which is taking the uterus out, is not actually a treatment for prolapse. The uterus is kind of an innocent bystander in the prolapse disease mechanism, because it is kind of getting pulled down because of other factors, but there's nothing typically inherently wrong with the uterus. Now, having said that, sometimes if most of the prolapse actually involves the uterus, then it does make a lot of sense for us to get the uterus out of the way so that we can do the prolapse repairs that we need to do. But we do have some patients who strongly desire to retain their uterus and to not have it surgically removed. And in those situations, we have a number of uterine preserving procedures where we can still fix your prolapse by keeping the uterus inside and not surgically removing that. And I think that is also something unique about our urogynecology program here, is that we do offer those uterine preserving procedures. And so again, our goal really is to come up with a treatment plan that suits our patients to the best of our ability. And because we offer such a wide variety of treatment options, we are very successful at that. And again, so we try and work with patients to figure out what their goals are and develop the treatment plan, if that involves surgery, the surgical plan that is right for them.
Thank you. Thank you for that answer there. Let's see, where were we? We have a few more questions coming in here. Let's see. Next question that we have up, what is recovery like for incontinence and prolapse? And I'll push that to Dr. Fairchild.
Like I was saying earlier, most of our surgeries nowadays are minimally invasive. And so typically recovery is pretty good. We're very successful here at minimizing the use of those strong opiate medications and kind of using a multimodal approach to pain control to keep patients comfortable as they're recovering. Most people are able to go home the same day if that's safe from a medical standpoint, and they may be taking some strong pain medications for a day or two. Usually after those first couple of days, we've moved on to kind of over-the-counter type medications. We're increasingly liberal about what people can do as they're recovering. We used to think, oh, you want to lay in bed, you don't want to lift anything, you don't want to do all these things because you're going to ruin your surgery. And the data hasn't really borne out that that's true. And so we're kind of increasingly liberal about letting people be pretty active in their recovery. Walking is great. It promotes blood flow. It helps your body and your mind stay healthy as you're recovering. And one of the things that comes up a lot for our patients is catheterization around the time of surgery. And most of our procedures, there is a risk that you're going to have some temporary difficulty emptying your bladder, which is really common with these types of pelvic floor surgeries. And so some of our patients do need to go home using a catheter, either with a catheter that stays in the bladder and they manage a bag, or a catheter that they're taking in and out of their bladder to manage getting the bladder empty. usually that's we handle that with just a couple of days and people are back to their normal. Overall, I think recovery, most of our patients would say is they usually say they have less pain than they expect and they feel better sooner than they expected to.
Great. The next question that I have up, it reads, I've heard that women often have to use a catheter after surgery. Is this true?
Yeah, that was I just answered that basically. And I think it really is one of our patients' primary concerns. You know, as they say, oh, I don't want to have a catheter. And we try to be very, very reassuring about that it's a temporary thing. And unfortunately, it's not something we can really control. It's either their bladder needs a little bit of rest or it's ready to function right away.
Thank you for reiterating that answer. The next question for you, Dr. Swenson, if my surgery is successful, how long will it last?
That is a great question. We do all of our surgeries here with the hope that it will last for the rest of our patients' lives, and they won't, we won't be needing to reoperate on them. But we know that there are prolapse recurrences, and a lot of that depends on kind of the patient's prolapse type and how big it is, and a variety of other factors. So while every urogynecologist would like to think that they have no prolapse recurrences, the truth is, we do have some patients who need another operation. But when we look at the data in terms of our outcomes, our native tissue repairs, so like Dr. Fairchild was mentioning, the surgeries that use their own tissues, we have really good results. When we looked at one of our apical suspension procedures, at 8 years, we had almost no prolapse recurrences at the apex or the top of the vagina. And so, and all of the patients who had a recurrence had a smaller prolapse than before the surgery. So, patients are definitely improved. If you do have a recurrence, that's something that, we also actually kind of one of our specialties is getting referrals for patients who have had a prior prolapse operation that hasn't worked for whatever reason. And so we have a lot of experience with that patient population managing these complex prolapses or recurrent prolapses. And so I don't want patients to ever think that if they have a prolapse recurrence, that it's something that they did, they shouldn't have been more, active, or sometimes they get the message that it's their fault that they have a prolapse recurrence. That is absolutely not the case. And that is, something that we are happy to always see patients and kind of provide them with another opinion in terms of what their treatment options are if that does happen.
Thank you for that answer. The next question that we have up reads, I have been utilizing a pessary for almost 5 years. Is this a long-term solution? And I'll push that to Dr. Fairchild.
Thanks, Ed. Just to remind everyone, a pessary is what Dr. Swenson talked about earlier, which is a small kind of silicone, basically a vaginal splint that helps hold the vaginal walls in place or helps to incontinence. They're fabulous devices for conservative or non-surgical treatment of both prolapse and incontinence, and they're very safe to use long-term. We have patients that we see in clinic that have been using them for 20 or 30 years. And, people figure out pretty early on if they like their pessary or if it's something they don't want to do. And as long as you're not having complications, which can occur but are pretty infrequent, where people get recurrent bleeding or recurrent issues with the pessary, as long as it's functioning well for you, treating your symptoms adequately and not causing you problems, it's a very safe device to use long-term.
Thank you for that answer. It looks to me like we have 5 questions left. I don't know if everybody's free to answer those. Okay, sounds good. We'll push on ahead. The next question, and I will ask this one to Dr. Swenson, reads, why is my leakage worse at night?
Well, I would probably need a little more information to answer that question specifically to a specific patient, but I can say I do get a lot of this question similar to this with a lot of the older patients that I see. And so I'll kind of answer it in that context. What we know about bladder function and how that changes with aging is actually, as we get older, most of our urine production actually shifts to the nighttime. So that's part of our normal physiology of aging. Part of that is related to the blood vessels in your legs, actually. They get less good at being able to fight against gravity during the day and return that blood flow to the heart during the day. You might notice you have a little swelling in your legs towards the end of the afternoon or the evening. And what that means is when you lay down to go to bed at night, all that blood that is pooled in the bottom of your legs gets returned to your heart. That blood then goes to your kidneys, and you actually have increased urine output at night. So part of that could be related just to the normal physiology of aging. Now, there are certain things that can be done to kind of modify that, to get that urine output to happen earlier than the evening time. So you can kind of take a rest in the early afternoon where you elevate your legs and kind of encourage that blood to get back to your heart sooner than bedtime. You can wear some compression stockings, which also can help. And then there might be some things that can be done in terms of the timing of your fluid intake in the evenings. So, if you're somebody who kind of sips on water or a glass of wine or beer in the evenings, all of those things, if you're drinking more in the evening, you're going to make more urine at night as well. So, there are a variety of reasons why somebody might be experiencing more urine output in nighttime.
Thank you for that, Dr. Swenson. And a relatively similar question for you, Dr. Fairchild, which reads, what can I do about leaking stool?
So leaking stool or accidental bowel leakage or fecal incontinence, they're all just different ways to say that you're having trouble controlling stool coming out of your rectum. Either it comes suddenly and you can't make it to the bathroom, or some people are kind of leaking stool without noting it and just finding it in their underwear. These are common things that happen to people, but really rarely get talked about and have significant impact on quality of life and can be frankly devastating for patients. I think one of the key things is that if you're having new onset leakage of stool, that really deserves a medical evaluation. Approach your primary care about it. We also have a clinic here at the University of Michigan called the Michigan Bowel Control Program, which really focuses on multidisciplinary care for people that are having bowel control issues. For basic counseling, you want to try to identify if there are dietary triggers. Like, are there things that are making your stool so loose that it's difficult to control? Are you maybe lactose intolerant? Could you have a food sensitivity that's new? Those can be things. The other issue that comes up a lot for people is irritable bowel syndrome and kind of issues that arise with that, where your stool is unpredictable. Sometimes you're constipated, sometimes it's very liquid and very urgent and you can't control. It can also be related to damage sustained at the time of childbirth to the sphincter muscles that are supposed to help you control stool. Those are all things that can be kind of sussed out in a clinical evaluation. Identifying those dietary triggers and avoiding them. And also importantly, physical therapy is a really key tool we have for treating bowel leakage. Often, most people that we see in the Michigan Bowel Control Program for leakage of stool, that's going to be at least part of what we do to treat their leakage. But I think the bottom line is, if you're having new onset leakage of stool, please don't suffer in silence. Come in for an evaluation and get checked out.
Thank you for that. The next question that we have up reads, I'm having some problems after my vaginal delivery and no one seems to know what to do. Dr. Swenson, can you offer any advice?
Sure. So we have a special clinic at the University of Michigan called the Michigan Healthy Healing After Delivery Clinic. And this was actually started in 2007. It was the first clinic of its kind in the United States. And this clinic is dedicated solely to women who have recently delivered, given birth, who have any kind of pelvic floor disorder. So we see women in this clinic for prolapse, for symptoms of urinary incontinence, for lacerations that involve the sphincter muscle that Dr. Fairchild was talking about, is if they're having trouble holding in stool after a recent delivery involving one of these tears. We help with the kind of identification of any kind of injury to the sphincter that needs to have another repair, or identify what is the cause of these pelvic floor symptoms. We also see patients who might be experiencing pain, pelvic pain, longer than they think would be normal or expected. And so we have experience with all of those pelvic floor disorders in the specialty postpartum clinic. And both Dr. Fairchild and myself see patients as part of that clinic. Also, we send a lot of our patients to Carol from that clinic because one of the things that we have learned, with our experience in this clinic and pelvic floor rehabilitation after delivery is that getting the pelvic floor to be optimally recovered really involves physical therapy. And that's a key component for a lot of these patients who are suffering from postpartum pelvic floor disorders. So we have a really good relationship with Carol and our other pelvic floor physical therapists and rely on them heavily to help a lot of our patients who we see in that clinic.
Thank you so much for that, Dr. Swenson. And my final question of the night is for Carol. This question reads, should I try to avoid drinking water at certain times of the day to reduce my incontinence issues?
So I'm always a little concerned about telling women to reduce their fluid intake overall because of the problems of dehydration. But if you think about it, you want to make sure that you're taking that fluid in a time of day that your body can process it before it wakes you up out of a sleep. So if you're having problems where you're super thirsty in the evening, then maybe take a look at that and try to shift your fluid intake earlier in the day.
I think too, one of the key things about fluid intake is that what Carol was saying earlier, where there's kind of a happy spot, right? You don't want to be dehydrated, but you also don't want to go crazy, like drinking tons and tons and overloading your bladder. And really moderation throughout the day is key. So like drink sips throughout the day. Don't chug 20 ounces all at once because you think you're behind on your fluid. Your bladder's not going to like that. And those are kind of my key recommendations.
And I'll just also add to that, because often patients are wondering, well, how do I know, what is the right amount to drink? And the 8-ounce glasses of water per day, which a lot of people have heard is the correct amount of fluid to drink. That's based on no science whatsoever. And everybody has different fluid intake needs. So it varies from day to day. So I tell all my patients to just look at their urine and use their urine color as a guide, because you want your urine to look yellow. You don't want it to look very concentrated and dark, that dark amber color. But what I find is a lot of my patients, their urine looks like water or almost like water. And what that means is that their kidneys are working overtime to get rid of a lot of excess fluid that their body really doesn't need. So in those patients, it is appropriate for them to cut back a little bit on their fluid intake. And again, just use their urine color as a guide to hydration.
Thank you so much. Thank you all for being such good sports. It looks like we've got through all of our questions. So that's really the end of our chat together today. Dr. Fairchild, Dr. Swenson, Carol Buis, thank you all for sharing your time and your expertise with us today. And thank you too to our audience for spending part of your day with us as well. You can learn more about our services at www.umwomenshealth.org. One more time, that's www.umwomenshealth.org. So we hope today's chat has been helpful, and have a wonderful afternoon.
Thanks, everyone.
Thanks.